All right. Good evening and welcome to Cases from the Community. Investigators discuss available research guiding the care of patients with ovarian and endometrial cancer. I'm Dr. Shannon Westin, and I'll be moderating the meeting this evening. Here are our faculty for today. I'm joined by Dr. Joyce Liu from the Dana-Farber Cancer Institute, Dr. David O'Malley from The Ohio State University, Dr. Alessandro D Santin from Yale University School of Medicine, and of course, Dr. Ritu Salani from UCLA. Welcome, faculty. And these are the relevant faculty conflicts of interest. All right, and these are Dr. Love's disclosures. And then here is the commercial support for today. Research to Practice CME Planning Committee, staff and reviewers have no COIs to disclose. This program will contain discussion of non-approved uses of agents and regimens. Please refer to official prescribing information for each product for approved indications. All right, so let's get started. In advance of the program, Dr. Love interviewed 7 general medical oncologists and gynecologic oncologists who presented cases and posed questions on a number of key clinical issues. Video excerpts from these interviews will be featured throughout the program. And this is where we're headed today. Dr. Liu would begin us with an upfront treatment of ovarian cancer. Dr. O'Malley will then talk about relapsed refractory ovarian cancer. Dr. Santin will talk to us about HER2-directed therapy. I will take us into endometrial cancer with first line for advanced. And then Dr. Salani will finish us up with recurrent and refractory endometrial cancer novel strategies. So let's move into Dr. Liu's presentation. Take it away.
Right. Thank you so much. So I'm going to talk about upfront treatment for advanced ovarian cancer, really concentrating on the role of PARP inhibitor maintenance. And we'll talk about how biomarker testing informs decision about PARP inhibitor maintenance, the updated data for the PARP inhibitor monotherapy data in ovarian cancer, the data that we're starting to see about IOs plus PARP inhibitors, and some thoughts about what the future holds. So when we think about ovarian cancer, we know that BRCA mutations and HRD are common in ovarian cancer. And BRCA1 and 2 mutations occur across the epithelial ovarian cancer subtypes except for mucinous ovarian cancer. So patients with newly diagnosed epithelial ovarian cancer should be referred for germline genetic testing for consideration for their family members and downstream testing. Now, 50% of high-grade serous ovarian cancer has evidence of homologous recombination deficiency. A lot of that is driven by mutations in BRCA1 and 2, including 5 to 6% that are somatic, so tumor-only mutations. But as you can see here, there are a lot of other HRR alterations that make up that other 50% of the pie. When we think about testing for homologous recombination deficiency, I really think about it, you sort of think about it in 3 stages. There's what's the cause of the actual homologous recombination deficiency, and these are things like the BRCA1 or 2 mutation or BRCA1 promoter hypermethylation. And then we think about functionality, like that's what actually is causing that loss of ability to repair DNA double-strand breaks by homologous recombination, but we can't test for that in the clinical setting yet. And so what we're really testing for is the consequence of homologous recombination deficiency, because when cells cannot repair their double-strand breaks with homologous recombination, they get this pattern of scarring, a genomic scarring that is a permanent pattern that we can see. How does this inform how we start thinking about frontline PARP inhibitor maintenance? And I really put this in 3 big buckets. There's patients with BRCA-mutated tumors. That can be somatic or germline. There are patients with BRCA wild-type and HRD test-positive tumors. And then there are patients with BRCA wild-type and HRD test-negative tumors. And we now have a number of studies. Oh, this is not the right slide deck. But we have a number of studies that actually inform this. Sorry, this went the wrong way. But we have PARP inhibitor monotherapy studies, PARP inhibitor plus bevacizumab studies, and we have studies of PARP inhibitor plus IO therapy. So starting off with the patients with BRCA-mutated tumors, this big bucket, and here you can see that PARP inhibitor monotherapy maintenance significantly improves progression-free survival for these patients, hazard ratios of 0.3 to 0.4, very consistent. And when we look at the long-term effect of this is a 7-year 2-year follow-up from the SOLO-1 study of olaparib maintenance therapy in BRCA-mutated ovarian cancer, you can see in this curve to the left that the median OS, there was a trend that was quite clinically relevant towards benefit with a hazard ratio of 0.55. And really impressively, when you think about time to first subsequent therapy, which is basically a proxy measure for first recurrence, you can see you stop the PARP inhibitor at 2 years, and 5 years later, there's a significant portion of patients who would have had recurrent disease who have not yet recurred. So for the first time, really raising the possibility that we are altering the expected natural history of ovarian cancer. What about other PARP inhibitors? We now have the final overall survival analysis data from the PRIMA study. This is 6.2 years of follow-up of niraparib maintenance therapy. You can see here that the median PFS benefit is very profound in patients with BRCA-mutated tumors, and that has been preserved. But for the OS, this is completely overlapping. The hazard ratio is 0.94. Why is this? We don't totally understand these results. Are these different patient populations? PRIMA has a higher risk population. Could that have been contributory? Is it that there's more percentage of crossover to the PARP inhibitor in the PRIMA study, which we did see? But I think growingly, we're also asking the question, is there an impact of PARP inhibitor, progression on PARP inhibitor on future therapies? And this is a retrospective analysis that came from the PALA-1 study, where, as you can see here, patients who had progression during receipt of PARP inhibitor therapy, their response and their clinical benefit from subsequent line of chemotherapy was actually less than patients who either had progression after having completed their first-line PARP inhibitor maintenance or the patients who got placebo. How about the combination of bevacizumab and olaparib? Is this something that is relevant for patients with BRCA-mutated tumors? And here you can see from the PALA-1 study the results from the primary PFS and final overall survival analysis, both of which are positive. The challenge here is we don't know how this compares to olaparib alone because PALA-1 did not have a control arm of olaparib. Moving on to patients with BRCA wild-type and HRD test-positive tumors, these are the studies that we think about. The PRIMA study looked at niraparib monotherapy, and ATHENA-MONO looked at rucaparib monotherapy. And here again, you can see this improvement in progression-free survival that is quite clinically relevant. When we look at overall survival, the data that we have currently is from the PRIMA study. This is the final OS analysis, again, with 6.2 years of follow-up. You see, again, that maintained progression-free survival benefit, but overlapping OS curves, a hazard ratio of 0.97, so no demonstrated overall survival benefit. How about the combination of olaparib and bevacizumab in this study? Again, with PALA, you see here the primary PFS and final OS analyses, very positive on the primary endpoint of progression-free survival. In the final OS analysis, there is a trend towards benefit, but this is not statistically significant. The hazard ratio is 0.71, but crosses 1. Finally, we have our patients with BRCA wild-type and HRD test-negative tumors. And when we look at this, again, the PRIMA and the ATHENA-MONO studies of niraparib and rucaparib, respectively, are what we look at. You can see there's a very modest PFS benefit of just about 3 months for these patients. And again, in the final analysis from PRIMA, looking at OS, there was no difference in terms of overall survival, this hazard ratio 0.93. When we look at the combination of olaparib and bevacizumab, we see that this does not improve outcomes compared to bevacizumab in patients with BRCA wild-type HRD test-negative tumors. So adding olaparib to bevacizumab doesn't improve things here. You can see the completely overlapping PFS and OS curves. What about the addition of IO to PARP inhibitors? And this is a question that has been asked for a long period of time because there has been sort of compelling rationale for this. We know that PARP inhibitors cause DNA damage. This can lead to increase of cytosolic DNA, which can activate the STING pathway, generating a type 1 interferon response. So you can see how these could be potentially synergistic. And in the lab, we see this. So these are actually from 2 different labs reporting in preclinical models of ovarian cancer. And you can see here that the combination of adding a PD-1 or PD-L1 inhibitor to a PARP inhibitor resulted in better outcomes in these mice than it did with either agent alone. But in the clinic, that has been a little bit harder to show. These are the data from the ATHENA combo study, which looked at the combination of rucaparib and nivolumab compared to rucaparib alone. And you can see here it did not improve PFS. And in fact, the hazard ratio was 1.29, 15 months for the combination compared to 20.2 months for the rucaparib alone. Now, why could that have been? We do know that the combination did result in a higher degree of side effects. And you can see here there were more dose interruptions or dose reductions and even dose discontinuations for the combination. Where we know that rucaparib is an active therapy as maintenance, this sort of decrease in the dose intensity may in fact have caused an underperformance of this combination arm. We also have a couple of other trials. So DUO-O reported positive results that demonstrated PFS improvement with olaparib, dostarlimab, and bevacizumab, so a triplet combination against the control arm of carboplatin, paclitaxel, and bevacizumab. You can see here this hazard ratio of 0.63 and sort of this change in the PFS curves. But the issue here is that we don't have the control arms that tell us this could not be from olaparib or olaparib and bevacizumab. So this could have been actually maybe a PARP inhibitor trial as opposed to an IO trial. And most recently, we also saw the results of KeyLink 001, again, a positive trial demonstrating a PFS improvement of olaparib and pembrolizumab with or without bevacizumab compared to the control arm of chemotherapy with or without bevacizumab. You can see here the PFS curves in both the PD-L1 and the intention to treat population. The overall survival here, as reported, did not show a difference, but again, the biggest issue with this trial is we still don't have the control arms to tell us this couldn't be from olaparib or olaparib and bevacizumab. So where does that put us overall and what still lies ahead? I think it's really important that we do think about testing for BRCA mutations in HRD status and newly diagnosed advanced ovarian cancer. It helps inform us what we do for PARP inhibitor maintenance. I do think that for patients with BRCA-mutated disease, germline or somatic, it's really important for us to be recommending PARP inhibitors to these patients unless they have a clear contraindication. For patients with BRCA wild-type or HRD test-positive disease, we do see clinically relevant PFS benefit, but this has not translated to date into a clear OS benefit. For patients with BRCA wild-type and HRD test-negative disease, we have very modest PFS benefit. There is no overall survival benefit, and these are patients to whom I typically do not recommend PARP inhibitor maintenance. What's still to come? We do have additional results that we're expecting, including studies that are hopefully going to help us understand the contribution of adding bevacizumab to PARP inhibitor versus PARP inhibitor alone. And tomorrow we will see the results of FIRST, so hopefully giving us a little bit more clarity about what is the contribution of IO when we have a triplet or doublet combination. I have a few last thoughts about where we go from here. One is, what is the optimal duration of therapy? And I think this is something that we've talked about. There are patients who don't want to come off after 2 years. There are patients who are really waiting to come off any moment. And if you look at the SOLO-1 curve, so this is recognizing these are in patients with BRCA-mutated tumors, and you say, what happens after 1 year? You can see that the event rates actually on the Kaplan-Meier curve look very similar as you sort of come beyond 1 year. And so this has raised the question, do you need a full 2 years of PARP inhibitor maintenance? And so NRG-GY036 is now open and enrolling, is looking at the question of 1 versus 2 years of maintenance olaparib in patients with BRCA-mutated or HRD test-positive ovarian cancer. Now, just to be really clear, I would not truncate anybody's PARP inhibitor maintenance based upon this Kaplan-Meier curve alone, but I think it really raises the question that's worth asking. The second thing I think is really figuring out how we identify patients at risk of early progression and those who have exceptional prognoses. You can see that 27% of patients are progressing on PARP inhibitor, even in the context of a BRCA mutation. These patients need something more, or maybe they need something different. And then we have these 20% of patients who have remained disease-free on placebo. These patients might not have needed a PARP inhibitor at all. And who are these patients and how do we identify them? And finally, I think as we all recognize, we really need options for our patients with HR-proficient tumors. PARP inhibitors are not giving us a lot of benefit in this population. Bevacizumab is not giving us a great deal either. And so I think here is where there's a lot of space for development. One of the questions is, will ADCs be able to move in this space and benefit some of these patients?
Thank you so much, Joyce. That was amazing. We're going to transition to our first case presentation.
Good evening, everyone. I'm Neil Love from Research to Practice. To enhance the clinical relevance of this meeting, over the last few weeks, I met in individual Zoom recording sessions with community-based general medical oncologists and gynecologic oncologists, Drs. Spencer Bacow, Gigi Chen, Kareem El-Sawi, Victoria Giffey, Eric Rupard, Kelly Schneider, and Lindsay Wilmot to present cases and query the faculty on the stage about their experiences and relevant research findings, beginning with Dr. El Sawi, who is a 65-year-old woman presenting with moderate ascites and a mental caking and found to have HRD positive, BRCA wild type, high-grade serous ovarian cancer.
The questions here to be asked of the experts for their opinion is how would they go about deciding whether to start with neoadjuvant chemotherapy versus primary debulking surgery? If they do neoadjuvant chemotherapy and interval debulking surgery, do they use HIPEC? And then if the patient shows an HRD status that is positive by a genomic test out there that has not been one of the compendium diagnostics used in the clinical trials, how much weight do they put on that? We started with neoadjuvant chemotherapy, followed by an interval debulking surgery. And because she had ascites and some pleural effusion, we gave her bevacizumab. The question here is about the continuation of bevacizumab in the adjuvant setting and whether to continue with the PARP inhibition besides the bevacizumab. The second question is if this patient actually had a BRCA mutation, either genomic or genetic, would that change that calculus of the adjuvant regimens to give in your minds? And the third question would be, what would be your choice of PARP inhibitors and what would be the duration of treatment that you typically would use or prefer, given the variety of PARPs that we have?
Okay, there's a lot to unpack there. So let's get started with the first few questions. I'm going to go ahead and combine these first two and talk. I'd love for you, Ritu, to talk to me a little bit about how you decide whether or not you're going to start with neoadjuvant versus primary. And for those patients that you do opt for neoadjuvant, what situations, if any, do you use HIPEC?
Yeah, it's always a challenging clinical situation. And as a surgeon and someone who does chemotherapy, I feel like these patients should really be evaluated by a gynecologic oncologist. And if complete debulking is feasible and safe for the patient, I do think primary debulking surgery, taking into accountability the morbidity, is kind of preferred. But neoadjuvant can be very reasonable for patients who are medically unfit for surgery or just maybe not optimized, or patients where debulking with complete resection is not ideal. In regards to HIPEC, and I also want to refer you to the ASCO guidelines on neoadjuvant chemotherapy for advanced ovarian cancer. But in regards to HIPEC, this is still an evolving discussion. There is data from Netherlands that shows an overall progression-free and overall survival benefit. And we're replicating the study through the GOG here. And one of the reasons why is this was kind of done in a time where BRCA and PARP inhibitors weren't really utilized, so kind of understanding how the molecular impact is. I do think it's an important opportunity to use HIPEC in patients, particularly if they haven't had the best response to chemotherapy but are resectable, so those who have a chemo response score of like 1 or 2. But I think it's still something that we're going to get more data on and how the molecular landscape informs that.
I think it's also important to say that tomorrow morning we're going to see the results of the TRUST trial, which is looking at neoadjuvant versus primary debulking surgery. So that first question may get spun on its head depending on the results from that study. And I think this third question is so important. So Alessandro, I'd love for you to take this. The question was around the different genomic testing platforms. So if you've got something from one group versus another, do you care if it had the companion diagnostic? Or will any testing platform do for you if you're making decisions around the use of PARP inhibitors?
Yeah, I really believe that the most important thing here is really to take advantage of one of the commercially available platforms, because I believe that the most important thing for us is really to understand whether the patient is homologous recombination deficient or proficient, because that is what is going to dictate later on how we're going to treat this patient.
Yeah. I think that's a perfect, and I think, Joyce touched definitely on the idea that we can't test functionally yet, right? So we got to use the information that we have. Dave, what maintenance would you have recommended for this particular patient, HRD positive? And is there a particular PARP inhibitor you prefer? Would you have continued the Bev? How long do you continue maintenance? Tell us everything.
There's
about
everything
this.
in maintenance. Well, Joyce and I have debated this and talked about this a lot. I use a lot of Bev. And one of the aha moments was actually Philip Harder, another sub-analysis, Apollo 1, unplanned sub-analysis with all the limitations, looking at high risk versus low risk in these classic definitions. And he saw that the greatest benefit in Apollo 1, small numbers, was in the low risk patients.
Right.
Hazard ratio, I think, is 0.1, 0.18 or something. So when I looked at that, that was an aha moment to me.
Yeah.
I said, we do have a chance for curative intent. Joyce and I were just debating this earlier with regards to advanced ovarian cancer, which Joyce so wonderfully showed in her review. So why would we deny our patients the best therapy? So yes, I use Bev. I continue Bev for a year for most of the randomized trials. And then because of most of my patients get Bev, then olaparib is really the choice. So the NCCN guidelines did update this year with regards to potentially niraparib versus olaparib, but looking at Apollo 1 in that group of patients, and then for 2 years on the PARP inhibitor.
And would you do anything different if it was a germline or a somatic BRCA mutation as opposed to HRD positive?
If I've started the Bev, I continue it, but I tell you, if they have any toxicities, I drop the Bev.
And then maybe Joyce, I know you just covered this in your slides, but do you think there's going to be a role potentially for checkpoint with PARP, or are there any subsets that we might be able to eke out some benefit?
I mean, I think we've had a really difficult time teasing that out. I used to be much more optimistic. I thought triplet therapy is going to be the answer. And, the PRIMA study has a press release. It's positive. We're going to see those results. But I think it's really going to be a question of how positive are those results going to be, and are they truly practice changing? We're asking patients to get an immunotherapy on top of everything else. And there's a price to that. And we have to understand, is that price worth paying?
Yeah. Great. We're going to go to our second case.
The next case was presented by Dr. Schneider, a 73-year-old woman who's found to have stage 3 high-grade serous ovarian cancer and received carboplatin paclitaxel, interval debulking surgery with a wedge hepatic resection, and 2 more cycles of chemotherapy post-op. In considering primary maintenance treatment for this patient, Dr. Schneider faced a challenging dilemma.
Her HRD was inconclusive from 2 separate genetic companies, and she was BRCA wild type negative. So my question for this patient is, would you recommend maintenance? If so, which one do you recommend? What do you do when it's HRD inconclusive? It's not an issue with obtaining enough tissue because we sent them plenty. It's just we've done all the testing we can do and we still don't have an answer. So after we talked about it in detail, she did elect to start a PARP inhibitor. She originally started niraparib. Unfortunately, she was not able to tolerate it. So we held it for profound thrombocytopenia down below 20,000. And at that point, I guess my next question is, would everybody still proceed? Would you move to a different PARP inhibitor? Would you keep trying that one at a lower dose? She had already started on kind of the mid-range dose.
Anything you want to ask them about that to discuss?
We normally check labs every week for a month. Is that what most people are doing? Are there any other ways to anticipate this in a patient other than the kind of the typical weights and plates that we've been told? I felt like I did everything correct in starting the correct dose, and we surveyed her, but we still ended up having to give her platelets ultimately.
So I see you switched her to olaparib, which you've been taking now for 3 years.
The plan was originally to do niraparib per that trial, which was 3 years. The olaparib trial was 2 years, but that was for BRCA. So we did have the discussion at 2 years that was a standard for olaparib. She said she was doing great. She absolutely did not want to stop at 2 years. So then I said, well, we'll use the data from the niraparib trial and go to 3 years. And so now we are about to be at 3 years. She's doing great. Her last CT scan was negative. Her CA-125 is normal. Her question for the group is, in light of that she is a stage 3, she's done extremely well, tolerating this well, would everybody insist on stopping at 3 years?
All good questions. I think let's start. I think we've all encountered inconclusive HRD results, so I'm going to move right through that. But Dave, do you have any tips and tricks for how you might increase the likelihood of getting an interpretable HRD test result?
Well, I think we do a lot more laparoscopy now. Some of it is because it's hard to get in at the time of diagnosis. It's hard to get into our interventional radiologist. Mm-hmm. The other thing is, communicate with your interventional radiologist at the time of diagnosis regards the number of cores, and we usually encourage as many 7 to 10. But with laparoscopy, you can overcome that with larger biopsies. So I do a lot more laparoscopy, try to get that tissue before treatment. And then at times, I will switch the testing platform because some testing platforms have a very high level of the amount of tumor. And so that is another trick that we use. But in an inconclusive, and they had neoadjuvant, and the reason it's so necrotic, I tend to treat those patients as HRD positive because of their good response to platinum agents.
Yeah, so I think with that question, I'd love to just quickly, who would have recommended maintenance therapy for this particular patient? Just show of hands. You guys can vote too if you want, but yeah, and I think it's exactly because of what you just said, Dave, right? We get an idea sometimes if we get an inconclusive result, it's because there was such a great response to therapy that when we send tissue from the interval tumor reductive surgery, it just doesn't have enough tumor to test. So I think that's a really important point. Joyce, how would you have managed this patient's thrombocytopenia? Would you have switched to another PARP, continued niraparib at a lower dose, or discontinued? And also, I would love if you covered Dr. Schneider's other question about how often you're testing CBC, that type of thing.
Yeah. So I think, the thrombocytopenia is a known effect of niraparib, and it is somewhat mitigated by using the plate and weight based dosing, which Dr. Schneider had done. I test when I'm on niraparib, I test weekly, and I actually test for 8 weeks, which is more than some people do, but I've seen the platelets drop at the 4th or 5th week, and it's classic that right at the 4th or 5th week is when they really dive, if they're going to.
Yeah.
I usually dose reduce for that first occurrence instead of switching, but for patients who really just cannot tolerate niraparib because of the thrombocytopenia, I do switch it for another PARP inhibitor.
And then let's just cover this last question. Ritu, would you ever continue upfront PARP inhibitor maintenance beyond the recommended duration, assuming the patient's tolerating the therapy well and maybe doesn't want to stop?
Yeah, in the upfront setting, I don't think that that's something I definitely don't do that. And I think Joyce nicely showed the data of how that duration is actually being challenged in the opposite direction of shortening the length of interval of treatment. And we have to be cognizant that even though patients may be tolerating this well, there may be some side effects or sequelae that develop, including like AML or non-myeloid dysplasias, myeloid dysplasias, that you have to be mindful of. And it may be a low percent, like 1 to 2% with upfront therapy, but it can be fatal. And I think stopping this therapy is really important based on the duration. And I do hope sincerely that we actually are able to shorten it in the future.
Yeah, I think those curves that Joyce showed, I think really demonstrate how confident you can be. And it's up to us to really help the patient understand that she can feel safe. Okay, now we're going to move on to our next module looking at relapse refractory. Dave, take it away.
All right, so based on time, it really couldn't include platinum sensitive. Some of the questions will address that with information. So I really put this presentation around platinum resistance. We're going to talk about some of the ADCs. We're going to also talk about some of the trials which are coming down. But we're going to see tomorrow the relacorilant data, glucocorticoid antagonists. Talk briefly about the Keynote B96, which regards to immune therapy, and what does the post-ADC world look like? We'll talk briefly about that and hopefully have a conversation also. So one of the questions I get asked all the time is, well, MIRV only is 40% of patients. So there's a really nice paper poster by Tom Krivak looking at all-world data, which was, I think, 6,000 patients that they looked at with regards to the IHC testing. And with that, very consistent 40%. That's what we've seen in the trials. But the other question is, what happens if you use a different testing platform? And this is actually from this table or schematic is from the Sutro data, which we looked at not just using the 2+ scoring, but also 1+. So it really shows that about 40% will be high folate expression using the 2+ scoring. But there's opportunities, significant opportunities, to have these medium and low expressors. We've kind of arbitrarily drawn that at the 2+ at 25%, but 80 to 90+% of patients will have some folate receptor alpha expression. So I think it's important as we talk about some of this data about the utilization beyond just those high folate receptor alpha expression. And what is this? I'm referring to mirvetuximab. And the reason is, I think it's worth reminding, in MIRASOL, the first trial we've ever shown with overall survival benefit when we looked at MIRV versus physician and patient choice chemotherapy, showing not just a hazard ratio improvement in progression-free, but also overall survival with about a 30% improvement in both of those. And you see clearly the curves on OS, you have differentiation. The response rate, when we have these patients recurrent platinum-resistant cancer, you often need disease regression. Maintenance of disease is not good, and we saw 42% overall response rate versus only 16% with standard chemotherapy. This was then led to FDA approval in 2024. When we started using this more in real world beyond those patients in clinical trials, we started seeing some other toxicities. We've always talked about the visual and the side effects with the eye, and we know about 40% will have some blurred vision, though less than 1% will have to discontinue for the eye toxicities. But we will see GI, low-grade, very important antiemetic regimen upon infusion, and making sure that patients will report diarrhea, often the first or second cycle, so keeping that in mind with regards to symptomatic management. We also will see fatigue and neuropathy. Remember that rituximab, the payload, is antimicrotubulin. So you will see with longer therapy neuropathy. So very important to think about dose reduction, dose interruption in this group of patients. But yet the discontinuation rate in MIRASOL is only about 9% in those patients compared to about 15.5% in the standard chemotherapy. So what's next in the folate receptor alpha? Well, we're hearing lots about the topo-1 payload. And we see that in ARENA-S. Betsy Lee presented this year's SGO showing the updated with regards to dose optimization data here, showing nearly a 50%, over a 55% response rate at the higher dose compared to 22 at the 100 milligrams versus 120. 55% response rate in platinum-resistant disease. Really, are we looking at a new bar in this treatment? Mm-hmm. And that led to an ongoing trial where we're looking at ARENA-S at that 120 milligram dose versus physician choice, paclitaxel, topotecan, PLD, or gemcitabine. So that is ongoing, that trial's enrolling, and something to consider for our patients, obviously. But how about other data? Well, there's multiple other folate receptor, but I thought it was important that these are two agents that will actually see the more mature data here in the next 2 days at ASCO. So please check those out moving forward. Let's switch gears a little bit and talk about cadherin 6 or CDH6. And this is also very almost ubiquitously expressed. Ubiquitous is probably a little overstated, but as high as about 85% of patients in high-grade serous ovarian cancer will have CDH6. And with that, we have the opportunity here to target that in our antibody-drug conjugate. Again, these are all antibody-drug conjugates. Our DXD, which we also refer to DS6000, but our TXD. When we're really looking at this data from Katie Moore from last year's ESMO, once again, pretty amazing, almost a 50% response rate. And when we talk about disease control rate, the ones that are going above 0%, I'm not as excited about. But when you see almost every single patient get disease regression, even though they don't hit that 30% threshold of an overall response, you have obviously a very active drug here. And the duration response, almost a year. So pretty amazing opportunity we have for our patients. But yet, again, looking at what is the cost with regards to the side effect profile? So interestingly, the 60 patients we reported on RDXD, the discontinuation rate was about 15%, okay? Dose interruption about 36%, dose reduction 25%. And what were most of those reasons? GI, fatigue, and then mostly, though, is hematologic. So the hematologic toxicity on this in the TOPO1 payload needs to be managed. This also led to the phase 3 trial. We had to optimize the dose of RTXD, and so that's what the phase 2 portion is. Once that has read out the optimized dose, then we'll move into a phase 3, again, compared to physician and patient choice. Now, tomorrow morning, we're going to see glucocorticoid receptor antagonist. This trial, we only have the press release, but it was positive for progression-free and overall survival. Tomorrow, we'll see the data. Now, what is the reason that this was even considered? Because when you look at dating back almost 10 years of data, when we have the glucocorticoid receptor overexpressed in ovarian cancer, patients seem to do more poorly. And even looking at circulating cortisol, nighttime cortisol, measuring that led to worse outcomes in ovarian cancer if it was higher at night. So very interesting. So we did a phase 2. We actually, mostly ENGOT, did a phase 2 looking at dose optimization, continuous versus intermittent, versus, this case, nab-paclitaxel, because we wanted to avoid steroids. And what they showed was progression-free survival, which seemed to be slightly improved in the intermittent. But what was interesting is even at that time, we saw, again, a hint of overall survival advantage in the intermittent. So the decisions made to go forward with the intermittent dosing. So important is put it into context tomorrow when you're listening to the presentation. And what will that presentation? On Rosella, phase 3. And one of the changes that we made in this protocol was to dictate that the comparator arm was nab-paclitaxel. This was originally designed as physician choice, but we thought there would be too much concern that the control arm could underperform. So it was nab-paclitaxel in both arms, plus or minus relacorilant. And again, to reiterate, this has showed hazard ratios, 30% improvement, both in progression-free and overall survival. And you'll see the curves tomorrow. While preparing these slides, an email popped in, actually as a text from a friend, and said, B96 is positive. We had completely dismissed IO therapy, especially in the recurrent setting. I just said, put this out. It wasn't run in the United States. It was only run in ENGOT. Well, that's not true. There was some sites in the U.S. But this was weekly paclitaxel, basically plus minus Pembro, patient physician choice on Bev. Now, the only thing we have here is the press release. Progression-free and overall survival to statistically positive. Now, again, I'm curious to see these curves. I'm interested in see the Bev, particularly after the Key-Link data, which was interesting to say. How about the post-PARP world? Fiona Simpkins presented this year's SGO with regards to zirnasertib. We've had similar agents which were difficult to treat. These are WEE1 targeted agents. And these WEE1 targeting agents, we know that the cyclin check point is, if we can block that, we can then cause patients not to be able to have DNA repair, cancers, leading to cellular death. And what Fiona presented was the Denali trial. And she's looking at that top aspect, which was a 1 to 5 prior lines of therapy was the zirnasertib at 400 milligrams. And what we saw was 20% overall, but we identified a biomarker of IHC, not amplification, but IHC, very important, response rates of 35%. So we're taking that optimization with patients who are expressing IHC, and now we're going to dose optimize, 400 versus 300, and then go with the optimized dose and treat patients and see if we can get accelerated approval with that agent. So what are my takeaways? ADCs are obviously here to say north of 50% response rates, but we're not going to be able to give a topo-1 payload over and over. Most likely, we're going to have to test it. Multiple positive phase 3 trials, which we haven't seen the data yet. So we need to see that before we start talking about sequencing. How are we going to make decisions about weekly paclitaxel or weekly taxanes Bev versus Pembro versus relacorilant? Or is there another option? All three. We have Bella, which is looking at relacorilant and Bev, weekly taxanes. And what are we going to do in the post-ADC world? We need to start thinking about those options. Thank you very much.
Thank you so much. So now we'll go to a case from Dr. Wilmot.
The next case is presented by Dr. Wilmot, a 44-year-old woman with a BRCA1 germline mutation who was diagnosed with ovarian cancer in 2018, almost simultaneously with the initial presentation of the SOLO-1 trial of maintenance olaparib in patients with BRCA mutations. This patient was then able to receive off-label treatment with olaparib for 2 years and did well until a year ago when disease recurrence was detected.
She was treated with platinum doublet plus bevacizumab, as she had never had Bev in the past. It's a platinum-sensitive recurrence.
I guess this question also brings up the issue of PARP inhibitors in recurrent disease.
I talked to her about it, because she had excellent response, obviously, to her first-line therapy, and she had been off of the PARP inhibitor for a while at the time of her recurrence.
And then how did she do when she was on the olaparib? I see she had anemia and dose reduction.
Yes, she had anemia that did require dose interruption, and then upon resumption of the olaparib, she had recurrent anemia. So with a dose reduction, she did really well, and she was able to stay on the 250 for the rest of her treatment. She was like the poster child for PARP inhibitor maintenance, and I actually got her on this medication right after SOLO-1 was presented. So it was a while ago now. It was before we even had any of our actual indications. So she was one of the early ones.
Wow.
Yeah. They pretty much put out the New England article essentially like the day after the presentation. So I just sent in the publication and it was not a problem.
Wow. So at this point, how long has she been receiving this second round of maintenance olaparib?
I think probably at least a year. I think my biggest question in this particular patient population is what people are doing in terms of length of maintenance. Because when you look at these recurrent maintenance trials, the treatment went indefinitely. And obviously the longer term data from the recurrent publications did show increasing numbers of AML and MDS, like doubling. So I'm curious if people are stopping at the 2-year mark like they did for SOLO-1 or if they're continuing indefinitely.
Great questions. Dave, why don't you take this first one? Which patients do you consider or would you might attempt a re-challenge with PARP inhibitor after disease progression?
Yeah, so, the patient who progresses on PARP outside of a clinical trial, I'm not going back to. Okay, if we can overcome that resistance. The patient who stops therapy because they've completed their 2 years of therapy and then they recur at a later, when we look at the OREO data, that is a group of patients that I absolutely would consider re-challenging with a PARP maintenance. Now, in the OREO data, which again, I didn't have time to present, it looked like the benefit was really dominated by a small number of patients. They didn't tell us who those patients were, but I assume those are patients who had discontinued PARP and then went back, then had the recurrence. So for me, when we're looking at that, if they stopped, I'm thinking about it. Now, the time frame. We're looking at 4 to, is 8%. I wrote up the Ariel 3 data looking at the extreme responders. And extreme responders, we hit almost 15% MDS rate.
Yeah.
So I have that conversation, even though the phase 3 trials, most of them have been, removed in the indication, except for BRCA patients. I had the conversation early on to say, if you're still responding at 2 years, I would like to have you stop, though clearly that's not what we did in the trials. Is that going to make a difference? When we looked at the subset on aerial 3, almost all those patients were beyond 3 to 4 years. So for me, I'm not going to go beyond that 2 to 3 years unless there's really a reason, like that persistent disease. But even that, a lot of that ends up not being persistent disease.
Ritu, would you treat somebody that had progression on a PARP inhibitor? Would you ever consider retreating with a PARP?
Only on a clinical trial. So I think that, maybe a combination would be appealing, but no, otherwise I would not.
And Alessandro, how long do you continue PARP inhibitor maintenance in this recurrent setting? Say in this retreatment setting or in someone that didn't get it up front and you're giving it to them in the recurrent setting?
So in my practice, again, in a patient with, again, as David said, so if the patient has presence of disease, visible disease, of course, I keep on going with the PARP for as long as the patient tolerates well and she has the disease under control. Okay. That is the straight question. In patient with, of course, at the end of the story, no evidence of disease, I think that the 1 or 2 years that we discuss is what I usually do.
Anybody do anything different?
I think if you're going to continue a PARP inhibitor in these patients that do have higher risk, getting CHIP testing, which I work with my hematologist because it might tell you which patients are at higher risk for MDS, and really paying attention to their CBCs and having a low threshold to refer them to a hematologist for bone marrow biopsy or further evaluation is important.
That's a great point. Great point.
Okay, second case here.
The next case, presented by Dr. Bacow, a patient with recurrent ovarian cancer, informs us quite a bit about the ups and downs of antibody-drug conjugates.
This is a 78-year-old woman with a history of recurrent high-grade serous ovarian carcinoma that also harbors a BRCA1 germline mutation. Next-generation sequencing showed 90% expression of reduced folate receptor alpha, HRD positivity. She began mirvetuximab in September of 2023 and has developed a complete response and remains on it at this time. However, at one point, she developed significant interstitial pneumonitis requiring steroids. Treatment was paused at that time, and she was off of therapy for a while until she was cleared by the pulmonologist. She now has mild shortness of breath, but she continues on mirvetuximab in an attenuated dose and a schedule that is not in the package inserts, but she remains in a complete response. So my question for the experts are, how long can one continue mirvetuximab? Do people ultimately develop some form of toxicity that ultimately requires them to come off the medication? Is it mostly ocular toxicity? Do you see lung toxicity as well?
Incredible case. Has she had any ophthalmic toxicity?
She had a little bit in the beginning. At this point, she has had no problems with her eyes.
And how symptomatic was she with the interstitial pneumonitis?
She had some mild shortness of breath, but her imaging was scarier than actually her presentation. Her CT scan had a lot of interstitial thickening. Although she was never hypoxemic, she just had some subjective shortness of breath on exertion.
Any other questions?
Yeah, so in patients that receive TDXD that develop substantial pulmonary toxicity, the medication is discontinued. Does that rule apply to other antibody-drug conjugates, such as mirvetuximab, soraventansine? If a patient develops only mild pulmonary toxicity, can they be rechallenged in the future? Even if you're not supposed to do it, I guess I'm doing it right now.
I love when you admit when you're doing something in the absence of data. That's always a good. So, Joyce, why don't you kick us off? How long, I think this is a question for all of these different drugs, right? How long would you continue MIRV for this patient who's in complete response, provided that there's no tox, let's say?
Yeah, I mean, this is in the platinum-resistant setting. So even in patients who have a complete response, I continue mirvetuximab indefinitely as long as they're not having intolerable toxicities.
Does anyone discontinue at a specific time among the panel?
Platinum-resistant ovarian cancer?
Platinum-resistant, yeah.
Not unless toxicity in that inpatient population. I will extend out the dose. I try to really maintain them at 5 milligrams. If they require dose reduction to 6 to 5, I really try to avoid 4. I actually am much more apt to increase the interval with regards to tolerance than before going down to 4.
Controversial. I totally agree with what he said, but I think this is a potential role for ctDNA in the future.
Yeah. I would love to see something outside of these imaging and things like that. Alessandro, can you talk a little bit about what degree of ILD would prompt you to permanently discontinue MIRV? And you're about to give us a masterclass on HER2. So is that the same paradigm that you would employ for TDXD?
So I can tell you that with TXD, we have clear guidelines in terms of how to handle, again, grade 1 versus grade 2 or above. With mirvetuximab, again, it's a little bit different. So I think that is more a personal choice of actually the investigator taking care of the patient. In this case, she was re-challenged with the mirvetuximab and looked like that she did well. So again, I think that is there is always cost and benefit here that you have to consider. And in this situation, again, the re-challenge with the mirvetuximab worked. So I think that there is the possibility to do what he did.
Yeah. Anybody do anything different in regards to re-challenging with Merv?
You know, one thing that TDXD has taught me is if I get a patient with a CR or what looks close to be a CR, and I have to interrupt for toxicity, I'll follow them. I don't restart another therapy. So in this particular patient, I would have most likely followed her. And if I started to see her disease start to progress at that time, I most likely would have reintroduced Merv, obviously with consult pulmonology, which he had done. So, you know, and I've been really surprised at how long we can get disease control once we interrupt some of these ADCs off of therapy.
And then have you seen benefit when you restart it?
Yes.
I realize this is anecdotal, but interesting. Anyone else restarted after a long pause? Joyce or Ritu?
Not that I can think of.
Yeah. So I think we'll move on. I think we talked quite a bit about toxicity and discontinuation. So let's get into HER2 therapy. Alessandro, you're up.
Thank you, Shannon. So in the next 10, 12 minutes, let me tell you a little bit about the role of HER2 targeted therapy in gynecological cancer. Let me start with the minimal background. The epidermal growth factor type 2 receptor, HER2 encoded by the CRB2 gene on chromosome 17, is a transmembrane receptor that includes an extracellular ligand binding domain, that is what is recognized by the antibody that we're going to discuss during my presentation, a membrane spanning region, and an intracellular tyrosine kinase domain. HER2 function as the preferred partner for heterodimerization with all the other EGFR receptor, and therefore playing a crucial role in coordinating the signaling network of, again, of the two pathways that I'm going to discuss in a second. The problem is that in cancer, HER2 overexpression, that most of the time is related to gene amplification, trigger an overcrowding on the membrane of the receptor, and therefore the receptor, the tyrosine kinase, become constantly activated, and this causes the dysregulation, again, of the PIK, AKT-mTOR pathway, and the RAS-RAF, MAPK that are downstream. So what is the frequency of HER2 expression in gynecological cancer? Let me start with uterine cancer. This picture that I'm showing you here, I'm sure that everybody has already seen this thousands of times, is the molecular classification published in Nature of uterine carcinoma. But to me, the important thing that I want to emphasize here is that HER2 amplification is an extremely rare event in polyultramutated and microsatellite high endometrial cancer, extremely few copy number low, but as you can see here, 1 out of 4 of the copy number high cirrus-like harbor CRB2 gene amplification. And this is a study from my own group published 6 months before the TCGA data that I just showed you. And again, emphasizing that in uterine serous carcinoma, the CRB2 amplification can be even higher. In particular, if you're including, like in this case, over 25% African-American patient in the sequencing. What about uterine and ovarian carcinosarcoma? This is another study from my group where we specifically looked to CRB2 amplification in carcinosarcoma, and is only to show you that two things. Number one is that the study was done to understand if this tumor were really unequivocally epithelial tumor that were going through metaplastic transformation during the lifetime, and we were able able to show that. But the important thing for the topic that we're discussing today is that 16% of the uterine carcinosarcoma, they were harboring CRB2 amplification, in particular, the one with the high-grade serous component. What about ovarian cancer? CRB2 amplification in high-grade serous ovarian cancer is a rare event. And in fact, these are, again, TCGA data, less than 5% of the ovarian cancer sequenced by the TCGA demonstrated a gain of function on chromosome 17 that I'm showing you here. And finally, in cervical carcinoma, the gain of function in CRB2 is even lower, 3.6% in the TCGA data. But importantly, HER2 mutation were identified in about 6% of the patient. And this is relevant for what we're going to discuss at the end in terms of an HER2 treatment. So what is the optimal source material and the timing for HER2 testing? The recommendation to clinicians is they should request HER2 testing on the tumor tissue or the biopsy, again, before initiating trastuzumab or ADC therapy. When HER2 status is, of course, being evaluated, the pathologist should perform immunohistochemistry first, followed by FISH testing in the equivocal cases, so the 2+. Positive 3+ or 0-1+ HER2 result, they do not require, again, the FISH testing confirmatory result. One important point that I highlight here in red is the pathologist should identify and mark the area with the strongest intensity of HER2 expression by immunohistochemistry and test those areas with the FISH. Because with this simple strategy in my own institution, that is Yale, we went from a 70% positivity in uterine serous carcinoma to a 33%, again, highlighting the area with the strongest immunohistochemistry and performing the 2+ and performing the FISH in those areas. The prevalence of HER2 status may be discordant, again, between primary and metastatic tumor in about 20 to 25% of the cases. This is important to remember, in particular the patient have been pre-treated with chemotherapy. And per NCCN guideline, clinicians should combine chemotherapy and HER2 targeted treatment as initial treatment, again, in HER2 3+ positive, 2+ positive, FISH positive gynecological cancer, as well as, again, treat both 2+ as well as 3+ expressing HER2 with, in this case, TDXD. So what are the published research studies that support this type of thinking? The first study that I wanted to show you very briefly is the GOG 181B. This was a phase 2 trial using single-agent trastuzumab in recurrent endometrial carcinoma patient. This is a study that started in the year 2000, so 25 years ago. And unfortunately, it was a negative study. We did not detect a single CR or PR in this group of patients, but there were a lot of flaws in this study. In particular, only 50% of the patients, they were CRB2 amplified. And again, and this includes all histology. So the conclusion of that study was that trastuzumab single agent was not really active. The TAPUR study that was published more recently, as that I'm showing you here, and there were few patients responding, as you can see here, with PR, but a significant number of patients, even if they did not reach a 30% cutoff of the PR, again, as you can see here, they benefit from treatment. This was a combination of pertuzumab and trastuzumab in HER2 and HER3 amplified endometrial cancer. The majority of patients that responded as expected were uterine serous. But the point is that from this preliminary study, we now know that endometrial cancer, similar to other solid tumor, have unique characteristics in terms of HER2 expression and gene amplification. And accordingly, again, there are different specific HER2 scoring criteria that should be applied. And here I'm showing you the picture of Dr. Busa at Yale University that has looked to hundreds of this uterine serous carcinoma treated in my institution. And she was, again, the one that reported a few years ago the peculiar characteristic of the overexpression, in particular in uterine serous. showing that these tumors, unlike breast cancer, are highly heterogeneous in the expression of HER2/neu, with over 50% of the 3+, again, FISH positive, harboring area of disease that I'm showing you here that were completely negative for HER2/neu, as well as over 75% of these tumors were lacking, again, apical HER2/neu staining that is more typical of gastric cancer. So with this knowledge, we design a phase 2 randomized trial with carboplatin and paclitaxel plus or minus trastuzumab, specifically targeting uterine serous carcinoma patient with either 3+ or 2+ FISH positive disease. And the rest is history. This was a study done as an IIT with a consortium of investigators. Many are here with me. David is one of those, where we enrolled 61 patients and divided in 2 arms, and we were able to demonstrate for the first time that adding trastuzumab was increasing PFS significantly. I'm going to show you that number in a second, as well as overall survival. And this triggered the revision of NCCN guideline. They now recommend, as to a category, the use of trastuzumab in combination with carbopaclitaxel in advanced or recurrent uterine serous carcinoma. Importantly, again, this study is now being validated further with NRG Guide 026 that is currently ongoing, that started as targeting also USC and with a couple carcinosarcoma, and that has been recently reopened, including all histologic type of endometrial cancer. These are the data that I just mentioned to you, adding trastuzumab, increasing the overall population, so advanced stage and recurrent, of about 4.6 months, the PFS, as well as, again, when you look to the stage 3, stage 4, it was able to double from 9.3 to practically 18 months, the PFS. And this, of course, was also followed by a significant increase in overall survival, both in the overall population as well in the stage 4 patient. So the good thing, of course, is that trastuzumab, we have shown here that it is effective, but can we do better? Because trastuzumab here was combined to carbopaclitaxel, so can we really take advantage of antibody-drug conjugate? That they have the backbone of trastuzumab through a linker is attached to it, a toxic payload that is even more potent. And these are, again, the data that I'm showing you here, again, the Destiny pan-tumor trial that everybody in the last couple of years is talking about. As you can see here, we were able to demonstrate that the use of ADC, in this case T-DXd, is order of magnitude more potent than the naked unconjugated antibody. As even more important, we were able to demonstrate that not only 3+ positive patient, but also 2+ FISH negative were highly responsive to this treatment. And here I show you even better, again, with higher magnification, the data. But I think that the most important thing is also to the fact that T-DXd has been able to increase PFS and overall survival, compare again to our control data. And another important point is that T-DXd is extremely potent, and therefore you don't need the large overexpression of HER2/neu to trigger clinical responses, as demonstrated not only in the 2+ FISH negative that respond in the range in uterine cancer of 47% or 40% in ovary and 36.8% in cervix, but as you can see here, even 1+ tumor, or even few 0, they responded to treatment. So we discuss again responses, but for sure we have to also consider the toxicity. ADC are in general better tolerated than chemotherapy, but may trigger side adverse events that are similar to chemo. And these are, again, the T-DXd data on the Destiny pan-tumor or to adverse event. As you can see, the majority were related to GI toxicity and bone marrow toxicity, but it's important also to remember that this ADC, in particular T-DXd, may also induce some rare or peculiar type of adverse event, in particular interstitial lung disease that we have discussed in the last few minutes, right? So in the Destiny pan-tumor trial, the incidence of ILD was 5.9 at the dose of 5.4 milligram per kilogram. That is the dose we're currently using for the majority of solid tumor overexpressing HER2/neu, but can be up to 14% when you're using the gastric dose. So how do you approach this? So the take-home message here is that the early diagnosis and the prompt treatment are crucial. You don't have to underestimate the presence of interstitial lung disease. So in the asymptomatic patient, where you do the CT to evaluate response and you see that the patient has interstitial lung disease, you have to put on all treatment. Perfect. And that, I think, and many of us are going to also start this patient on 0.5 milligram of prednisolone or similar to hurry up again the process. But the point is that if the ILD resolves within, again, 4 weeks, what we usually do, we restart treatment the same dose. If it takes more than 4 weeks for the ILD to reverse back to normal, you may restart TDXD at the lower dose. And again, and finally, the criteria is that if the interstitial lung disease persists above 48 days, you should discontinue the treatment. For grade 2 and above, of course, we have to, again, put the patient in the hospital and give him.
Yeah, it's very firm. I think that's a really good point to end on, is that anything above grade 1 for TDXD, you are not retreating that patient. So let's go to this case presentation.
The next case, presented by Dr. Schneider, is a remarkable commentary on the evolution of research in antibody-drug conjugates. A 75-year-old woman with stage 4, HR-proficient, BRCA-negative, high-grade serous ovarian cancer with positive pleural fluid and bony involvement, with disease progression after treatment with carboplatin, paclitaxel, bevacizumab, and interval debulking surgery.
Her alpha folate receptor was 95th percentile, and her HER2 was 3 positive. Her PD-L1 was also positive. She did not tolerate chemotherapy well, does not like it. Her CA-125 is elevated now, and her CT scan shows recurrence, which would put her at being platinum resistant. So I would normally lean at this point toward TDXD or mirvetuximab. My question for these rare patients is, does anybody have one that you recommend first? Mirvetuximab because it's more established, or TDXD? A big issue I've had with mirvetuximab in the past is worsening neuropathy, because almost all of these patients have gotten paclitaxel at some point, and so they're already dealing with neuropathy. She looked over both and was very concerned about the neuropathy. It has been a big issue for her. Her husband cannot drive, so she's the driver in the family, and so she was worried about visual changes. So she elected to do the TDXD. We've just started, but she's had 2 cycles, and her CA-125 is showing improvement from 120 to 53. She's doing great.
Yeah, so I mean, I think this is a really clinically relevant, and she said it's a rare patient, but I feel like I've been seeing more and more these patients that have positive folate receptor alpha and positive HER2, and I'd love just to hear quickly from each of the faculty members how you might sequence those drugs. Joyce, do you want to kick us off?
Yeah, I mean, I think that we have a positive phase 3 study that shows an overall survival benefit for mirvetuximab in platinum-resistant ovarian cancer. And the TDXD data, as exciting as it is, it's really in 40 patients and it's single arm. So, I mean, I think that, from a standard perspective, I give these patients mirvetuximab first, and I would love to see a head-to-head comparison. I think, similar to you, I see patients who are HER2 expressing, but it's less the 3+, because I think it's about 5% of the population. But that overlap of patients who are HER2 2+ and 3+, where the Pan-Tumor 2 study sat, I think that's where we really should ask this question.
Dave, what about you?
Yeah, I think, we have a survival advantage.
Yeah.
So I'm going to favor that. But in this patient, if she's just worried about neuropathy versus she has pre-existing neuropathy.
Right.
If she's worried about it, so we'll watch it closely, we'll use symptomatic management, we'll dose reduce, again, maybe increase even the interval. But in a patient who comes in who already has profound neuropathy, in that scenario, in a 3+, I may actually go to TDXD. But I really, with a survival advantage, and then we need to go with those agents. Excited about Pan-Destiny, small numbers, expression of 3+.
Alessandro, anything different to add?
Not much, but once
convinced
again, mirvetuximab has shown the overall survival benefit. So I would go with that, knowing that most likely I'm going to follow with the TDXD after.
Okay, and Ritu?
Yeah, I agree. I would use MIRV first, and I think she's going to see both. I think the other thing is that, mirvetuximab having the DM4 payload may be better before the topotecan payload, so.
Write it down, people. The whole panel agreed. It's good. I love it. Dave, what about the emerging results with Keynote B96? Do you think that Pembro is going to be a consideration now for platinum-resistant? Obviously, you need to see the data and how you might sequence. Would you care about PD-L1? I think lots of good questions here.
Yeah, I mean, the CPS positivity, 1+. I mean, we're going to have to really see that data. But we are going to be forced to decide between relacorilant, Bev, or Pembro, potentially as a combination with weekly taxates.
Oh.
So I think we're going to have a lot more of these conversations over the next year as we see that data.
Okay, great. Maybe a little quick round robin. Just which of all these investigational strategies are you excited about with advanced ovarian cancer? I'm going to start with you, Ritu.
So I'm going to mention one we haven't talked about. It's Claudin-6, so keep your eyes out for it, emerging data.
I think that TROP2 target is really very hot, and then maybe I'm biased. I just finished a phase 2 trial in ovarian. I cannot
Might
tell
be
you
a
the
little biased.
results.
What about you, Dave?
Yes.
Yes. Okay. Good
All
answer.
of them.
Good. I love that. Joyce?
In the immediate future, I really think the ADCs, but I think really understanding which patients are going to respond best to which ADCs is the question we need to know. Yeah.
And I'm a big fan of the WE1. Also, I'm a little biased.
Yeah. I like WE1.
I have an Alessandro-like bias towards WE1.
But
okay.
biomarker
Yes.
data needs to be there.
Yes, absolutely. Okay, we're going to go to another case.
Right here.
The next patient is presented by Dr. Bacow, an 80-year-old woman with HER2-positive, MS-stable, T53 mutant metastatic uterine carcinosarcoma with disease progression after carboplatin, paclitaxel, trastuzumab, and then after receiving lenvatinib, pembrolizumab.
Given her HER2 status and her progression on multiple prior lines of therapy, we started her on TDXD, trastuzumab deruxtecan, and she has at this time developed a CR, and actually she's developed MRD negativity by a circulating tumor DNA assay. So my question for the experts are, in patients that develop refractory uterine cancer that is HER2 overexpressing, would you immediately proceed in the second line setting with TDXD, or would you save it for a later line therapy and try other types of therapies such as lenvatinib, pembrolizumab, or another form of cytotoxic chemotherapy before proceeding?
Really great case. How did she do in terms of acute GI toxicity? How did you pre-medicate her, and how did she actually do?
So she has had no GI toxicity. She receives lots of pre-medications with her TDXD. She gets Zofran, she gets Tylenol, she gets famotidine, she gets some steroids. We certainly haven't seen any lung toxicity with her either. She's tolerated this medication very well.
Are you doing preemptive pulmonary scanning, looking for ILD?
So yeah, in the beginning, I've been doing every 6 to 8 weeks a CT chest. But since this patient is getting a scan every 3 months, and she's been on it a little while now, we're doing it every 3 months. But if she even gives us a slight hint of shortness of breath, she's getting a CT scan.
Fair enough. Okay, so let's first, I'd love to hear from the faculty, maybe just a show of hands. For patients with HER2 positive endometrial cancer, are we doing checkpoint, PD-1, PD-L1? Are we doing trastuzumab? Again, HER2 positive. Let's start. Are we doing trastuzumab? Who's doing trastuzumab? I like a little trastuzumab. What about PD-1?
It depends, yeah.
Yeah, I like that too. What about all together? Would you do everything?
Sometimes bevacizumab.
Sometimes bevacizumab. For who would you do bevacizumab?
P53 mutants.
Okay, based on the 86P data, nice. And would anyone, it looks like this question is, are you combining it with, we doing carboplatin, paclitaxel, trastuzumab, and a PD-1? Is anyone doing that? Okay, no one's going off the rails quite yet. All right, perfect. And then I guess the next question, which I also think is a good one, and I'll throw this one to you, Joyce. If this patient's disease recurrence were diagnosed today, what would you give second line, TDXD or LenPem?
I mean, I am leaning towards LenPem. We have a randomized phase 3 trial that shows OS benefit. I mean, you're considering what patients can tolerate. There are some patients who aren't going to be able to tolerate LenPem, but minus any contraindications, I'm still going with LenPem first.
This panel likes people to live longer. I approve of that. And I think we talked about monitoring. Did you like, Alessandro, did you like his plan for ILD monitoring?
I think that, the person that asked us the question is doing the right thing. So, pre-medication to try to keep to the minimum the nausea and vomiting, aggressive, use of 5-HT receptor antagonist. So, and also I don't know if I'm already skipping to the second part, but I think that the interstitial lung disease is also, I believe that, as I try to emphasize in my presentation, you cannot underestimate the possibility that is going to evolve. So stop treatment because it can become irreversible. And that is why, again, we've lost few patients in the original trial. And this because of what we're doing now, that we've been able to dramatically decrease the lethality of this type of adverse event.
Great point, Ritu. Yeah.
I was just going to add, I think he kind of covered it, but there were 2 patient deaths, and I think they were both from ILD. So that's 5% in the endometrial cancer cohorts. Many of these patients may have received immunotherapy, which may also have some pneumonitis effects. So it works that patients tolerate it well until they don't. So stay vigilant.
Minimum of every 9 weeks, CTs of the chest.
Yeah.
If they don't have disease in the chest, I never used to scan them. I scan everybody's CT of the chest. You were scanning at 6 weeks, you said.
In the beginning, yeah. I follow the guidelines, and but I don't scan their whole body every 6 weeks.
You do the chest at 6.
And then every 3 cycles, like every 12 weeks, every 4 cycles, I guess, is the full body.
Yeah, great. All right, that was awesome. We're going to transition now to the management of first-line therapy for advanced endometrial cancer, and I will be knocking this out. First of all, of course, I think, this is a very savvy audience, and we know that the backbone of treatment for advanced and recurrent endometrial cancer was based on the GOG 209 study, which compared the TAP regimen. Who here gave the TAP regimen? I know I'm not supposed to pull you. Yeah, I did. I give that poll all the time, and I'm usually the only one who's given it. But compared paclitaxel carboplatin to the TAP regimen and found that it was not inferior, and in fact, it had a better adverse event profile. And you've never seen this slide before, but what I'll focus on is, with the TCGA data, we wanted to move away from lumping endometrial cancer and get more into splitting, right? We want to understand how the molecular aberrations of endometrial cancer could help us drive therapy. And we know based on TCGA that the 4 BIND categories have an impact on prognosis and potentially response to immunotherapy. And there's ways for us to move it through the clinic. And so we have some very pragmatic ways that have been incorporated into the NCCN, to the European guidelines, where we can test our patient's tumor to understand what treatments might be best for them. And that includes checking for POLE, checking for the presence of mismatch repair protein deficiency, and then looking at P53. So the question is, with that backbone of paclitaxel and carboplatin and our understanding of the molecular aberrations that are present in endometrial cancer, could we do better? And there's a pretty nice rationale for why we saw so many trials that were combining chemotherapy with immune checkpoint. And that basically indicates, when we give chemotherapy, we see increased tumor cell death, but also immunogenic cell death. And this can potentially reduce the number of tumor cells that are producing those immunosuppressive mediators, potentially make the tumor more sensitive to immune checkpoint inhibition. We also see increased expression of tumor antigens, MDSC depletion, and Treg depletion. And so that all could potentially make this quite synergistic. And that led to fill your favorite checkpoint into this schema, where we saw a number of trials, including my own, where we had chemotherapy with or without a checkpoint inhibitor. And typically these were done in an all-comers fashion, although some did all stratified by mismatch repair deficiency. Some even gave us some nice statistical power. That was GOG 018, which looked at pembrolizumab. All of them looked at progression-free survival as a primary endpoint, understanding what the role of the addition of checkpoint was to chemotherapy. And these are the results. So these are the snapshot of results, first looking at that mismatch repair deficient group, because this is the group we would expect to have the biggest impact, right? This is our biomarker-driven group. And you can see across the trials, whether it's pembrolizumab, dostarlimab, atezolizumab, or durvalumab, that we have a clear benefit in the population with mismatch repair deficiency that receives a checkpoint in addition to their chemo, followed by that checkpoint maintenance. Around a 70% reduction in progression, which I think we would all agree is quite exciting. But there's a little bit, there's still some opportunity here, although I think everyone should be prescribing that. This is what this patient population should get. But there is a proportion of patients for whom this doesn't work, right? We see early progression in a population of patients. And it may be that mismatch repair deficiency is not the only way we should be driving response to therapy, perhaps TMB, perhaps other factors. And so there's still work to be done here, although this is no doubt an absolute win. So then the question is, what about mismatch repair proficient? Have we knocked it out of the park with that? And the answer is we still see benefit, right? Because of that synergy that I just spoke about with chemotherapy and checkpoint, but it's not quite as profound of a difference. We see about a 30 to 40% reduction in the risk of progression, or even a little bit lower depending on the trial. So there's definitely an unmet need in mismatch repair proficient disease. And I do think it's important we want to make sure we're not hurting somebody. So you heard from the panel, some of them would give checkpoint, right, to a patient with mismatch repair proficient HER2 positive disease. And these are some data that reassure us that we're not hurting people. You see trends towards, at least the same overall survival, no detriment in overall survival. And right now, this may be the best that we have, but certainly we're hoping that we can do better. So these were data that we put together out of our lab looking at homologous recombination deficiency. And you heard Joyce talk about the importance of this in ovarian cancer. So we wondered, is there something similar in endometrial cancer? And we found actually there was a high proportion of patients that had some aberration that should make them potentially responsive to a PARP inhibitor, including aberrations in BRCA, RAD51C, PALB2, and also ARID1A. Now, ARID1A mutation has been associated with potential benefit from PARP. So when we looked at all those numbers, we thought, about 50% of patients might benefit from a PARP inhibitor. And then we thought, well, why not check out to see if we can get some synergy between not only the chemotherapy and checkpoint, but also between the checkpoint and a PARP inhibition. Now, these are from the DUO-E study, and you can see that these two first lines are just when we're looking at the addition of durvalumab to chemo. And I already talked to you about the mechanism of action that might indicate that that would work in a mismatch repair proficient tumor. But when we layer on that PARP inhibitor, when we layer on that PARP as a maintenance, you can see we see some improvement in progression-free survival, and it's durable. If you look at that 18-month analysis, when we look at the landmark analysis, you can see that those patients that were treated with chemo alone, only 20% were progression-free at 18 months, compared to the group that got durvalumab and olaparib, 42%. So why might that be? Well, there's a couple of mechanistic things that seem. We know that olaparib induces DNA damage, and this can lead to immune priming, which may further allow for that robust anti-tumor immunity and a more durable benefit. And that is borne out by these progression-free survival data, as well as duration of response, which I'm not going to show you, but reached 18 months in that recurrent maintenance setting. So we're definitely increasing benefit for a longer duration. And I just want to make a note, because that's mismatch repair proficient. In mismatch repair deficient, we didn't see as much of a benefit for the addition of a PARP inhibitor. And I was surprised by this because I thought mechanistically it would work, but it seems, they do so well just with the addition of checkpoint that perhaps the addition of a PARP inhibitor just really doesn't push it any farther up. So, for mismatch repair deficient, it would seem checkpoint alone is beneficial. And then again, like I told you, if we're going to add additional drugs, and especially if we're adding PARP inhibitors where we've seen some issues with overall survival and other tumor types, we want to make sure we're not hurting people. And these are immature, but I think the trend is really nice that we don't seem to see any detriment in overall survival. And perhaps as we see more maturity, we'll even potentially see a survival benefit in mismatch repair proficient disease. Further proof of principle came from the RUBY study. This was a study that looked at the addition of niraparib to dostarlimab. Important to note that this was a chemo, just like DuoE, this was chemo versus dostarlimab and niraparib. There was no dostarlimab only arm in this study, and there was no niraparib only arm in this study, so you have to just take that with a grain of salt. But it did demonstrate improved progression-free survival for the combination in both the overall, the intent to treat, and the mismatch repair proficient populations. But really what we want to know, I just told you, we don't want to lump. So can we split, right? Is there any biomarker that might help guide our use of PARP inhibitors in this population? And these numbers in the RUBY-2 study get real small, real fast, so just be cautious. But you can see here there's a trend towards perhaps an increased benefit or an increased reduction in the risk of progression in the patient population that had a P53 mutation. But please note, there's 10 patients in the control arm, so we have to be real careful about that. These are definitely just hypothesis generating. And as expected, aberrations in BRCA and HRD potentially predicted response to that therapy. We also looked at this in DuoE. This is the forest plot looking at a number of different molecular aberrations, but again, focusing on P53, there's that trend towards improved progression-free survival, improved reduction in that population that's P53 mutant. But I would show you the hazard ratio for P53 wild type is 0.71. We used to get excited about that hazard ratio, right, guys? And so, that's nothing to sneeze at, right? So there may potentially be benefit across all these populations. We just need to do more study. And then finally, I think in that mismatch repair deficient group, the question is, can we get rid of chemotherapy entirely? So we have two studies that are going to help us understand that, the C93 study with pembrolizumab and the Dominica study with dostarlimab. Those are both moving checkpoint into the front line versus chemo in that mismatch repair deficient group. And as a note, we did see the results of LEAP, which was trying to do lenvatinib and pembrolizumab in lieu of chemo, but that did not meet its primary endpoint. So I think in conclusion, it's a bottom line, clear role for checkpoint in endometrial cancer, especially in that mismatch repair deficient group. And of course, we're all wondering, are we going to overthrow chemo with IO alone? And then really, we need further study in mismatch repair proficient. We're seeing incremental improvements and benefit, but there's still really an opportunity here to split this patient population out more, HER2, ER, PR, P53, and really understand what the role of PARP is in certain patients, and are there other strategies that we can use. And I'll stop there and we'll move to the case.
The next case, presented by Dr. Chen, is a woman with Lynch syndrome and stage 3C uterine adenocarcinoma.
This is a very nice 61-year-old female. She had a history of breast LCIS and had excision in 2008, and she was on tamoxifen until 2014. She does have Lynch syndrome from genetic testing and was diagnosed with uterine cancer. She underwent debulking surgery for uterine cancer in January 2024. Pathology showed a stage 3C, grade 2 uterine adenocarcinoma, DMMR. So she was started adjuvant carboplatin paclitaxel pembrolizumab. However, she had an anaphylactic reaction with paclitaxel. Therefore, treatment was switched to carboplatin, docetaxel, and pembrolizumab, and she completed 6 cycles in June 2024. She then underwent XRT, but we did hold pembro. And after she completed XRT, she's now on pembrolizumab maintenance. So some of my questions would be, which immunotherapy would be the best to use? And what are the criteria to kind of help decide whether to use immunotherapy or not immunotherapy? The other thing that's more practical to her was that in her case, we held immunotherapy during the radiation because of concern for more GI toxicities. I've heard that some people do hold IO and some don't during the radiation. So curious to see what should be kind of a more standard practice in that setting.
So good question. So I'm going to start with you, Ritu. How do you decide whether to incorporate anti-PD-1 or PD-L1 antibody in a patient like this? And is there a specific one you like? Do you think of them as essentially equivalent?
I think of them essentially as equivalent in the DMMR population. I think, you can use any of them. Personally, I tend to use the PD-1 inhibitors, but I think the DMMR data is pretty compelling across the board. What was your other question?
Oh man, you said they're equivalent. Yeah, no, I think you rocked it.
Okay.
And you just were you summarized it so much you thought there must be more. And Joyce, have you encountered increased GI toxicity when you have seen patients get checkpoint inhibition with radiation?
So before I talked about that, can I just make one point about this
I would
case?
love that.
The one thing I was going to point out is this is a true adjuvant therapy case. So, stage 3C, fully resected. And that population was not actually generally incorporated into the GY018 Ruby Duo E Attend studies. So the population was really covered by the B21 study. And in that case, right, we know sort of overall, there's no additional benefit for adding checkpoint therapy to chemotherapy as adjuvant therapy, except in the subset analysis of the DMMR patients. So I think treating this patient with anti-PD-1, PD-L1 therapy made a lot of sense, but I just wanted to make that clarification because I don't know that it came out completely in the case.
Yeah, and what about with radiation? Have you ever given that?
Moving on from that, I mean, this was a stage 3 case. I probably would not have given this patient radiation. I haven't really seen sort of that sort of interaction because that's generally not how I've practiced. But we have not, when I've given patients radiation, we have not generally held checkpoint therapy during it.
Okay, great. We're going to move on to the next case because he's got lots of questions for us.
The next patient, presented by Dr. Rupard, is a 67-year-old woman with MS-stable high-grade serous endometrial cancer and recurrence in the vaginal cuff after hysterectomy.
I treated her with carboplatin, paclitaxel, plus pembrolizumab. Her CA-125 had been in the hundreds and came down into normal range. She also had a really nice radiographic response with both CT scans and PET scan showing, essentially a complete response. So a couple of questions. Do you treat with some form of maintenance immunotherapy? And if so, for how long in a patient like this? Do you find that adding the immunotherapy to the standard carboplatin, paclitaxel makes it less tolerable for these patients? And what sort of issues are you running into in terms of side effects with that combination of treatments? Finally, what is the life expectancy for somebody with a relapsed, essentially unresectable endometrial cancer with the newer regimen of chemotherapy combined with immunotherapy? Are you seeing patients who are long-term survivors of this, or is this a patient who is, even with the combined chemoimmunotherapy, is likely to pass away from her disease within the next couple of years? Does the tissue type matter? Our pathologists often make this distinction between endometrial and endometrioid. And of course, we have high grade and low grade serous. Is there a difference in the responses that you see there? How does PD-L1 testing factor into your decisions? Do you always use the immunotherapy up front? Or are there situations where you give the standard chemo up front and reserve the immunotherapy for a relapse? And a question that almost all of us face in this crummy disease is, when a patient eventually progresses on immunotherapy, what do you go to next? Is there a role for a CTLA-4 checkpoint inhibitor?
Okay, there's a lot to cover here, but let's start at the very beginning. So, let's have Alessandro, let me have you tackle this. For patients with advanced endometrial cancer receiving upfront chemo in combo with a checkpoint, how long do you continue the checkpoint in the maintenance setting?
So usually at minimum 1 year. Again, this is a uterine serous anyway that is discussed. So I'm not really expecting the immune checkpoint inhibitor to provide much above the chemotherapy regimen. These are usually cold tumor, low TMB, minimal infiltration of lymphocytes. So that is why I think that the heavy lifting is really done by the chemotherapy in this specific patient.
Okay. And Joyce, what have you found with the addition of checkpoint to upfront chemo? Does this affect tolerability with patients? And what are kind of some of the most common issues you see with these combos?
I mean, I think we definitely see that you'll have the potential toxicities of immune checkpoint therapy, but in my experience, it really hasn't made it such that chemotherapy itself is less tolerable. It's just sort of that you have another set of potential side effects that you might have to deal with, and those are really the things that I look for. There's the chemotherapy side effects, and there's immune checkpoint inhibitor side effects, and I sort of track both of them.
Dave, do you agree?
Yeah, I mean, I tell my patients 1/3 chance you're going to have an IO toxicity. Most of those are going to be mild. We're going to be able to manage. Some of them we may do steroids. 5 to up to 10% will bet enough to definitely do steroids, even require admission. Probably lower now. We admitted a lot more people earlier on. And I say about a 1% up to 2% life-threatening or life-altering.
Yeah. Right.
If you burn out somebody's pituitary, it's definitely life-altering.
And Ritu, do you think are we curing patients? That's, I think, the bottom line about that last question there.
I feel more confident saying potentially in the DMMR population, definitely see some long-term responses, and I'm a little shy to say cure just yet, but I think the PMMR we're struggling, and I think that we may get some short-term responses, but I think you're gonna be so excited to hear my talk about recurrent options, where I think we're making progress.
Yeah. Dave, what do you think about the histologic type? Does this affect the likelihood of response? Alessandro kind of touched on this a little bit.
Well, thank you for answering my text when I ask you these questions, when I'm looking at patients sitting in front of me. I mean, the histological subtype still helps us, right?
Yeah.
But the molecular subtyping is really what's driving much of our decisions. If we look at the data which is being generated much by your work, looking at these molecular subtypes, who are going to benefit the most? And so for me, looking at those patients with DMMR, POLE mutations, it's right, just drop the mic. Those patients absolutely get IO. But what are the others? It's the now we have the PMMR. Is it the P53 mutated? If we're P53 intact, should we be looking at alternative options, even hormonal therapy? Yeah. So for me, the histology is important, but I really probably rely more on the molecular subtyping now.
Yeah, and we saw in DUOE, I mean, I expected it, but it was nice to see it borne out in the data that when you looked at the P53 mutant subtype, that wasn't driven all by serous, right? So again, indicating histology is important, but those molecular aberrations can really help clarify some of those things outside of histology. And then, I'll tackle this one. Do I think regimens, and I'd love to hear my friends talk about this too, but PARP inhibitors have a role in newly diagnosed, and where might I prioritize? For me, I'm eagerly, this regimen has obviously been approved in Europe and other countries where we can use the combination of durvalumab and olaparib in mismatch repair proficient disease. That's where I think it belongs right now. Do I think it's the perfect treatment for everyone with MMRP? Absolutely not, but I think it's one of the best options we have right now. So I would love to have the opportunity to use it in this patient population, especially kind of starting to tease out some of the molecular aberrations where we see the most benefit. So TBD, if that's a possibility here in the States. Thoughts about that? No pressure. I'm not going to get mad at you if you say something different.
No, I agree. I do think we needed more exploration on who really benefits. Do you really need the PARP-IO combo? Do some patients just benefit from PARP inhibitor? I love the idea of exploring the HRD/HRR genes. So I think it needs to be cleaned up a little bit.
Well, and I think part of the problem, and then we'll move on, is that, as Joyce talked about, the testing for HRD is tough in ovary. We have no idea what we're doing in endometrial cancer. I mean, we don't even know what level of these tests is positive. So hopefully some of these prospective studies we'll look at that and we'll report that so we can start to really tease out if that's able to guide therapy. And this last question, I know that Ritu's going to cover in her talk. So we are going to transition to our very last module, which will be looking at therapeutic options for relapse refractory endometrial cancer. Take it away.
All right. Well, thanks for sticking with us through this talk. It's been really informative, excellent talks, and I hope I can add to that. So I'm going to talk about endometrial cancer and kind of some new approaches. Before we get into that, I just want to review the management for recurrent endometrial cancer, particularly in the pMMR population with lenvatinib and pembrolizumab. You heard us talk a lot about checkpoint inhibitors in the front line, so maybe kind of what is its role in the second line. And then some really exciting emerging targeted therapy options. I'm going to talk about selinexor, TROP2 ADCs, folate receptor ADCs, and then some non-ADC options that I think really are going to play a role in endometrial cancer. And since 2000s, chemotherapy has become the standard of care, and 2010, carboplatin paclitaxel was the preferred regimen. But I always like to highlight that it's in these advanced and recurrent settings that 80% of these patients are going to experience recurrence, and most often that's going to occur within the first 2 years. And this is just kind of an overview of different studies, and this is looking at the control arm of these studies. All of these are in frontline, and you can see that the median PFS is actually pretty poor if for frontline diagnosis. So, and we really never had great therapeutic options in the second line. And so this study, which was published in 2022, looked at advanced metastatics and recurrent endometrial cancers really after frontline platinum-based chemotherapy. And it randomized patients to lenvatinib and pembrolizumab versus physician choice, which was doxorubicin or weekly paclitaxel. And you can see that it's stratified by MMR status, but I'm going to really focus on the pMMR patients. And the primary endpoint was PFS. And here you can see the PFS and OS data in the pMMR population, which really showed the advantage of len-pem in this population compared to physician choice chemotherapy. I always like to highlight the objective response rate was 32% versus 15%. It just reminds us that there was a really low bar in endometrial cancer, and we were able to double it. I still think it's a really low bar, though. Median overall survival was also improved, and you can see that hazard ratio of 0.70. And this quickly became adopted as a standard of care. Became a little bit disrupted with endometrial cancer frontline therapy incorporating immunotherapy, so I think we need to figure out which patients would be able to defer it to second line. And there are some toxicities, and you've heard us talk about toxicities throughout this symposium. Len-pem can be really tough for patients. Dose reductions are quite common, as are dose interruptions. But when you manage it appropriately, you can keep patients on it, but it is important to monitor and educate these patients. And I always like to include this slide from Dr. Mucker's study, which looked at adverse events, and it really shows you how quickly these come on. This shows you that this is in weeks of starting therapy, and you can see that most of these are going to occur within the first few cycles. So educating the patients well and having a good mitigation plan is going to be really key. What I really am excited to talk about is maintenance therapy in endometrial cancer. We now have maintenance therapy. You heard about PARP inhibitors, and we've talked about bevacizumab. We even have it in cervical cancer with immunotherapy in the frontline settings and in endometrial cancer. But I think there's opportunities for improvement. And I'm going to focus on selinexor. So frontline endometrial cancer now kind of has incorporated checkpoint inhibitors, and you really heard that this would be for those kind of advanced patients, those who have residual disease or stage 4 disease. But we know that that benefit is highest in those patients with dMMR tumors. And really the benefit is modest in pMMR. And I think Shannon brings up a great point that maybe PARP inhibitors play a role. And you heard that benefit in P53 mutations kind of maybe being a separate group. But we know that over 50% of patients with advanced and recurrent endometrial cancer are P53 wild type. And of those, P53 wild type and pMMR status actually is quite common, so 40 to 55% of those patients. And so this brings me to selinexor, which is an oral XPO1 inhibitor. So it prevents the export of P53 out of the nucleus, back from the cytoplasm back into the nucleus. And so what's really important is you want a functioning P53. And so this moves multiple tumor suppressor proteins back into the nucleus, including P53. And so the SIENDO trial was a phase 2 trial looking at selinexor maintenance. And so what they did is they had patients who received carboplatin and paclitaxel. Those who had a partial or complete response were then randomized to selinexor versus placebo. And what they saw in this study was that there was kind of this PFS difference of 5.7 versus 3.8 months. Not really that significant. But when they did this pre-specified exploratory subgroup analysis, they found that those patients with P53 wild type, functioning P53, there was really this pronounced difference of 13.7 versus 3.7 months. And this kind of gave them kind of this, okay, this makes some biological rationale, kind of a negative biomarker, if you will. And so this, warranted further exploration. Additional kind of analysis from the SIENDO trial, looking at the pMMR versus the dMMR population, showed that the pMMR P53 wild type had even a more pronounced response. And you can see this at 38.5 months with the updated data presented at ASCO, and versus placebo of just under 5 months. The dMMR P53 wild type also had a benefit, 13 months versus 3.7 months, but not nearly as significant. And so this kind of, I think, is starting to show us this difference in this, not looking at MMR status, but P53, really P53 wild type, pMMR, really may be an interest in for selinexor. Recently, Deb Richardson just showed us that this also had benefit in time to subsequent treatment, PFS2, and time for treatment starts. There are adverse events that we need to be mindful of, and so this is something that we take very seriously, especially with new therapies. Nausea and GI effects, vomiting, diarrhea, as you can see here, and then the cytopenia, so thrombocytopenia, anemia, and neutropenia can also be seen. You can see here, though, that treatment discontinuation in this was pretty low overall, but there are, ways to manage this as well. And so this has led to the confirmatory trial, which is ongoing now, called XPORT-EC 042. There are a couple differences in this trial from the original, including a little bit of a lower dose, so hopefully we'll see a little bit better management of those toxicities. But same concept of carboplatin and paclitaxel, patients having a partial or complete response, and this can be first-line or second-line treatment with that regimen, and then patients are randomized to selinexor or placebo. And you can see your primary endpoint PFS and secondary endpoint being OS, and I think this is a really exciting area where we may be able to target that group that doesn't get the best benefit from immunotherapy. And I think it's important because we may have len-pem as an option for those patients afterwards. So we can strategize which patients should benefit from which therapies and which sequence will be really important. So in the last couple of minutes, I just want to go over some emerging therapies. And you've heard about some of these even throughout some of these other disease sites because we're having a little bit of overlapping exposures. And so TROP2 ADC, and I want to compliment Alessandro, who's done a lot of work in this, and especially some pivotal work, where we've seen that TROP2 is a really kind of prime target in endometrial cancer. There are multiple TROP2 ADCs on the market. 3 of them are listed here. And, you can see here, and I should have updated the sacituzumab govitecan, 41 patients now. It's about a 22% response rate, but really heavily pretreated patients. So, we're talking about patients. Remember I told you in len-pem it was 15%? Now we're talking about patients 3rd line, 4th line, 5th line, and you're still getting kind of response rates in the 20%, which is pretty impressive. So these are pretty consistent, and these are now being pushed into the phase 3 trial. So we have these ongoing, and we hope to see the true activity of TROP2 in this setting. And there are several other ADCs that are exciting. You heard about HER2, and there's multiple HER2 ADCs that are in development or ongoing in studies. And you can see some really impressive response rates that I think are very exciting, but we need to confirm this and make sure this is real. TROP2, you've already heard about, and then folate receptor alpha as a target. This is something that is also expressed in endometrial cancer, and there are ongoing studies with different ADCs targeting this antigen. And there's others. B7H4, CDH6, Claudin-6, that I think we're going to continue to see this. So I think you heard earlier that ADCs are here to stay, and I think this is actually true across all disease sites. But there's also non-ADC targets, and I don't want to, be dismissive. You heard a little bit of comment about PARP inhibitors, and I think there is going to be a role for it. WEE1 inhibitors, which Shannon has also worked on, PIK3, AKT, hormonal therapies, mTOR inhibitors. I think there's a lot of opportunities to explore these, and I do think the molecular landscapes or targets are going to be really informative. And so I do think that, we need to be mindful. I do think phase 3 data is really important, but I think we need to be creative. So we have these FDA approvals for lenvatinib and pembrolizumab and trastuzumab deruxtecan as an accelerated approval. But I think the landscape for management is rapidly evolving. And we're going to continue to have probably more questions as we get more approvals. Who are the right patients for certain strategies? Is there an appropriate sequence for these patients? Do we use biomarker versus all-comer indications? And how do we navigate this? So I think this is a great start of the story. I think it's really just the beginning.
Amazing. Thank you. So let's get into this case from Dr. Giffey.
The next patient, presented by Dr. Giffey, has stage 4 MSI-high endometrial cancer. All right, 79-year-old lady.
This lady was diagnosed with a stage 4 MSI-high endometrial cancer involving her lungs last year. And she has chronic wounds from venous stasis on both legs distally. She had already been seeing an academic center who recommended giving Pembro with carboplatin and paclitaxel, as is standard for first-line therapy. I was worried about the chemo because of the potential for immunosuppression and infection of these wounds. So we started. I gave her weekly carboplatin and paclitaxel with the pembrolizumab, and she wound up in septic shock in the ICU after just one dose. She's done well on pembrolizumab alone since. She's still in a partial remission. My question is, when chemo candidacy is borderline with these MSI-high endometrial tumors, is it reasonable to just start with pembrolizumab alone, or do you always try to give people the benefit of the combination of chemo and IO? Or do you ever give Pembro and lenvatinib if you don't think they're fit enough for chemo?
Was she neutropenic when she had the septic shock?
Yes, after a weekly dose. This is a tiny dose.
You mentioned lenvatinib, pembrolizumab. What's your experience with that regimen?
I have given it quite a few times, mostly in MSI stable disease, and I found it to be decent. My patients have partial responses, not very many complete responses. In terms of tolerability, the lenvatinib is usually the troublemaker. So I wind up either starting at a medium dose if I'm uncomfortable with their organ function or their general performance status, and then climbing if they tolerate it. Since it's all palliative therapy, I rarely start with the full dose of lenvatinib. Anything preemptive they do about mucositis, which is a problem, especially at full dose. I haven't had too much of a problem with blood pressure or bleeding in my patients using lenvatinib for really any tumor. I do know that it's a bit controversial whether to start with the full dose and drop it or start with a medium dose and raise it. And I seem to hear it's kind of split across the board there.
Ooh, we'll have to see. Well, let's start there. I'm gonna throw a wrench here. Is it split across the board? What are our approaches for dosing lenvatinib? Do we start full dose or do we start a little lower? Joyce, I'm gonna start on your end.
I start full dose if I think the patient can tolerate it.
Yeah.
18 milligrams. If you start with 20, you get pill packs of only 10 milligrams. You know about 2/3 of patients are going to need to dose reduce. So I start at 18. So when we go down to 14, they already have the dose. Don't have to wait for a new script and don't have to be on 10 for those few weeks waiting for the new pill packs. So I start at 18. I think they're probably, and I don't have strong data to support this, there's probably something to try to get disease regression at the higher dose and then go down with regards to how they're tolerating it.
Alessandro?
I really personalize the dose of lenvatinib in my patient.
Okay.
Again, a patient has tolerated really well chemotherapy. I started around 20, but in my elderly women, with significant comorbidities that they were unable to tolerate the chemo initially, I start with 14.
Okay. What about you, Ritu?
I'm a 20 milligram starter with the exceptions. I do take some patients' comorbidities, frailty into consideration, and we'll start them at typically 14, but I rarely go up.
Yeah, I do wonder if there's something about getting that higher dose, and especially there is a proportion of patients for whom you won't have to dose reduce. So I start at the top dose too. And then Alessandro, for a patient like this with MSI high disease, maybe doesn't want chemo or chemo might be problematic. How do you feel about anti-PD-1 monotherapy? And would you ever use Len-Pem if somebody wasn't fit for chemo?
I must tell you that I was impressed at the ECR a month ago when I was here in Chicago, listening to the presentation using immune checkpoint inhibitor in colorectal carcinoma MSI high. It was an impressive type of response there. So I don't know if this is going to be duplicated in our endometrial cancer MSI high, but for sure in a patient like this, I would strongly consider that.
Yeah, we've seen some early phase 1 data. I think it was like 10 patients. It didn't seem as profound, right? There were no CRs, and I think it was a response rate maybe 5 out of 10 patients. So there are some differences between what constitutes mismatch repair deficiency in endometrial cancer versus colorectal. So it will be interesting to see those upfront studies and see what do you got for me?
I just want to say that there was a study of Len-Pem, right, in the frontline setting comparing it to carboplatin paclitaxel, LEAP 001, and it didn't meet its endpoint. And but if you look at the DMMR subgroup, which I'm not making any statistical comments on, it was a hazard ratio of 0.3. And so I think it's important to recognize that if you have a patient where you think chemotherapy is going to be detrimental, I would consider it. I'm not sure that the lenvatinib maybe in this DMMR patient would have done it. So I totally would have probably gone with the checkpoint inhibitor only therapy approach in this patient.
Go ahead, Dave.
Yeah, if you're worried about a patient tolerating carbotaxol, I'm not doing Len-Pem.
Exactly.
Len-Pem, we have weekly visits with the APP until we get a stable dose. And many of those are video visits. But again, keeping right on top of that, I can give carbotaxol in my sleep. Len-Pem is a ton of work. But if you do, you can maintain the dose. Now, with regards to, when we these groups of patients, again, individualizing is important. But we have the chance to get rid of their cancer so it doesn't come back, even recurrent metastatic setting in endometrial cancer and DMMR. I want to make sure that we are utilizing all our guns here.
Absolutely. Absolutely. Okay, let's go to the last case of the night.
We come back to Dr. Schneider for the last and very memorable case, the first we've seen presented in any of our meetings, of a patient with a POL-E mutant disease, also HER2 overexpressed and MMR proficient metastatic endometrial cancer.
She started second-line pembrolizumab and lenvatinib April of 2021. She did require dose reduction to 12 milligrams, but has done very well on that and has actually had continued improvement of disease. And so now we're rapidly approaching 5 years on this treatment for a patient that progressed on primary chemotherapy. Interestingly, she is POL-E positive, HER2 positivity, and P53 mutated. So I guess my question is, she's been on treatment for 4 years. She's still NED. I suspect that I have TDXD as an option if she progresses because of her HER2 positivity. Do I stop? She's doing great on it. She has no complaints. I've never seen POL-E before. I guess my question is, what would everybody do now in light of her very odd disease course and mutational profile?
So, what was the TMB? How high? Because it's supposedly, really high.
I think it was 92.
Yeah, well, I'm putting my money on that being the reason she's doing so well.
We did too. We talked about her as a group, mainly because I just want to feel okay about stopping everything. But the P53 kind of threw everything off, and her original presentation was so bad. And the progressing through chemotherapy immediately, all of those kind of make me hesitate to stop. But if we think POL is a driving factor now, I would feel more comfortable.
Yeah, I think this is a really interesting point because we haven't always been able to test for POL-E in all our patients just because of cost and such. And we've been doing it in patients that have a P53 mutation, because if you've got a P53 mutation in the setting of POL-E, probably not as big of a negative factor. We're still learning about this, but I do think that that's a really huge point. And Joyce, for this patient with the POL-E, if they presented today with newly diagnosed, how would you think through your initial treatment?
Yeah, this is a very unusual case, right? The POL-E patients typically have actually very good prognoses, so progression through primary chemotherapy is just very unusual. I would treat this patient with carboplatin paclitaxel and IO therapy, really leaning on the POL-E potential.
And Ritu, what do you think about some of the data that are emerging about maybe not having to treat patients with POL-E? Obviously, this is a patient with advanced disease. Certainly, it seems maybe potentially more safe in early stage. Any thoughts about that?
Yeah, there's studies ongoing, but I think it actually makes a lot of biological sense. And I haven't done it yet, but I would be quick to to want to de-escalate these patients. I also think lenvatinib and pembrolizumab in this patient is something I would not use. I'd probably just use checkpoint inhibitor only since she progressed. Her TMB is so high, that's another indication, and she should be exquisitely sensitive to immunotherapy.
That's a really good point, right? So we have a tumor agnostic TMB high indication for that drug, and so obviously that wasn't necessarily known when lenvatinib and pembrolizumab was started.
Yeah, so the trials, they discontinued Pembro at 2 years, and they continued lenvatinib indefinitely. We all just questioned the contribution of lenvatinib here. Yeah. So for me, I'd be very comfortable holding therapy and stopping therapy at this patient that polymutated.
Okay, we're coming up on the end, so I'd love to do what we did with ovary and see what investigational strategies our panel are excited about. And we'll start with you, Ritu.
Okay, so the question is, am I answering?
What investigational strategies? Just the first question. There's a lot going on in that question.
Yeah, I mean, I think it's everything, but I think, frontline, if we have opportunities for sustained progression-free survival, so selinexor in that P53 wild type is a really exciting therapeutic option for me.
And certainly getting in early, right? Maintenance. We want to try to get the best drugs as early as possible, right? So I agree. I think that's exciting. Alessandro, what do you have?
I'm biased.
Again, we already know what his answer is.
I'm working on TROP2, and I've seen amazing responses, and is overall well tolerated. As you discussed, we have 3 phase 3 prospective randomized study ongoing. They're going to tell us very soon, the final result. But I think that the TROP2 ADC are really emerging as a winner.
Yeah.
ADCs, I mean, the selinexor data is really cool. And we're seeing flattening those curves like we see in immune therapy, and flattening the curves with, again, small numbers. We'll have to wait and see. But, the disease is not coming back. So if we can have the chance of curing recurrent metastatic patients, we have to look at that. WEE1 inhibitors, same thing we had a conversation ovary. This post-ADC world, really may make a lot of sense in these, especially the P53 mutated.
Joyce?
So I would say that selinexor, absolutely, I'm very interested in that frontline maintenance setting. The ADCs, same comment I made about ovary. I think that there's going to be multiple targets and figuring out which of the targets for which patients. I love the WEE1 inhibitors in this setting, as you know well, and also other DDR targeting agents. And then the last thing that we haven't talked about is endocrine therapy.
That's what I was going to say.
Patients who are going to benefit from endocrine therapy. And I think we have advances, especially with the CDK4/6 inhibitors and the degraders.
Yeah, I think
it'd be really interesting.
I think we've all had patients that are on anti-hormones for years, so finding the right patient for whom you can do that and avoid chemo and other toxic agents is so exciting. Okay, well, we are at the end. First of all, of course, thank you to all the general medical oncologists and gynecologic oncologists for their contribution. And can I hear it for this group of faculty? What awesome panel we had. I'm just so thrilled that I got to spend the last 2 hours of my life with you guys. It was amazing. So have a wonderful evening and enjoy the rest of your ASCO.
Thank you.